Our first speaker, albeit recorded this morning, is Helen Goss. Helen graduated from Edinburgh University in 2006 with an MA Honours in Business and has since worked in numerous places around the world. She's extensive experience in media planning, buying and sponsorship with a range of clients. And she went on to run a successful business until the birth of her daughter, Anna, in 2012. Helen has a solid 8-year track record in the third sector, working with pregnancy sickness support, providing one-to-one peer support to women suffering from hyperemesis gravidarum. In 2020, Helen's daughter Anna, now aged 10, developed long COVID with PANS. Helen joined the Long COVID Kids team in 2021, stepping naturally into the role of COO in 2020 and leading the charity Scottish registration, being instrumental in raising awareness of long COVID in children in Scotland. In 2023, Helen became Long COVID Kids core participant in the upcoming Scottish COVID inquiry. Her commitment to ensuring that all families have appropriate access to paediatric long COVID care and support has been recognised by Scotland's First Minister. And we have a video to be played since Helen unfortunately can't be here today. Thank you.
Hi everyone, I am Helen from Long COVID Kids. Thank you for having me, and I'm sorry I can't be here in person, but if anyone has any questions, please feel free to get in touch. So I'll quickly do a brief overview of our situation. Anna was a healthy, happy wee girl, age 7, prior to the pandemic. No underlying health conditions. We contracted COVID in early on in March 2020, and she has not recovered. We've had 2 subsequent infections in 21 and 22. She does have a long COVID diagnosis now. It did take 2 years to get it, and she also has PANS and dysautonomia, and more investigations ongoing all the time. So we have had a really difficult time trying to access healthcare for her. As I said, it took 2 years to get her diagnosis. She's had a lot of rejected referrals, and we've had to go and seek out those clinicians privately to get her some treatment. She's been discharged from a number of things. The only thing we have coming up, which is via NHS Scotland, is rheumatology, but unfortunately Anna is so unwell right now. I can't get her to the hospital for that appointment, and I asked for a video consultation, but unfortunately they refused that. So I'm not sure how we're going to access it, but that's a problem for future Helen. The impact on Anna's life and my life and everybody around us's life, it has been enormous. Her life is so different now. She can't do any of her hobbies. She's more often than not housebound. We can't access education for her. It's another story. But even if we could, she would only be able to do a tiny bit sporadically. She has lost all of her friends, and sadly she is quite often refusing to see any more healthcare providers, even though she is horribly unwell. It's also been extremely expensive because all of the rejected referrals from the NHS, we've gone to go and seek out a private clinician to get her treated, and that has cost a lot. Sadly, our story is not unique. Even now, we're in our 4th year into the pandemic now, and even the new families who are joining our support services are unfortunately reporting very similar experiences even now than we have done over the past 3 years. It's just really awful situation at the moment in Scotland. So what is the clinical pathway like for children and young people in Scotland living with long COVID? Well, the very simple answer to that is there is no dedicated long COVID service for children and young people in Scotland, which isn't remotely funny. this diagram here on the right is a screenshot directly from the sign guidelines implementation note, which is essentially the easy read, cheap version of the full NICE sign guidelines. The first problem is that this implementation note is not easy to find online. You have to hunt around for it, and feedback that I've had from GPs that I've spoken to are that they don't know where it is, they don't know where to find it, and they haven't got time, of course, to go looking for it. Second problem is it's not exactly the easiest chart to read for a GP that is already overworked and stretched to their absolute limits. So I've simplified it on the left. In its simplest form, if a child presents to the GP and the symptoms warrant a pediatric onward referral, then that's where they should go. And then again, onward referral to pediatric specialists if required and allied health professionals. This all sounds great in theory, but at the moment it is not working just down to the very simple fact that the education and training doesn't actually exist at the moment for healthcare professionals to access. So it is pot luck whether you get a GP who has experience with long COVID or is knowledgeable, and then the same barrier when you get to pediatrics, same barrier when you go further on down the line. So this image is the epitome of accessing healthcare for children and young people with long COVID in Scotland right now. It is like navigating a system so confusing and with so many barriers and dead ends. Families are just simply getting lost in the maze and they can't find their way out to get any positive outcomes for their children. Wouldn't it be easier for GPs to be able to just direct families to one point of contact in each health board, a long COVID service for pediatrics? And I just thought that, the green ladder with bridge across all the noise and confusion of the multiple referrals, being pinged to pillar and post, which, appointments which may or may not come to fruition with very little continuity of care. It makes sense to me, but it's not happening. So families are often being forced, if they can afford it, to seek private healthcare. So after 18 months of advocacy groups, charities and patients screaming into the void for help, the Scottish Government instructed the National Services Scotland to set up the Long COVID Strategic Network. So the network goal is to aid each of the 14 NHS Scotland health boards in their planning, development and implementation of their long COVID services. So let's just take a minute to realise what that means. They are still planning the services. They're not there yet. On the right, we have another really fun, confusing chart. This chart outlines the network as a whole. At the top, you've got Scottish Government and then all the different groups beneath it. If you look closely, you might just see the lived experience group tucked away in there. The problem is nobody knows, none of us in the lived experience group are aware of who is in each other group. It seems to be a closely guarded secret. There is very little transparency between the groups. There's no reporting between groups. There's no communication or sharing or learning between the groups. Activity trackers aren't being shared. Lived experience is definitely kept at a distance from everyone else. And it's only following the recently published long COVID inquiry report that one person from the lived experience group is now permitted to observe the steering group meetings. Just observe, no input, one person. Given that the long COVID lived experience group consists of 7 different charities, who gets that one spot? I mean, it raises questions about equitable representation. Rather than compete for limited access, the focus should really be on fostering full transparency, comprehensive reporting between all groups, open communication between all groups, and collaboration. And that just isn't happening. Speaking of the long COVID inquiry, it's an interesting read. The committee did a really good job on the inquiry. The report is very comprehensive and the recommendations do reflect the needs of patients and lived experience. The Scottish Government's response, however, is not particularly ambitious. It doesn't quite hit the mark on understanding what the issues are, and quite often it does feel like a quick copy-paste job at times. I'm currently analysing the report and publishing it on a Twitter thread on my personal Twitter account. But I'm only on about page 7 of 17 right now, so it's slow going, but I'm getting there. So if you're interested in learning a bit more about it, reading more about it, then please do go and have a look at my pinned post and join in the fun. Anyway, thank you very much for having me again, and I hope it's been a whistle-stop tour of the uphill battle that we're having in Scotland. If anyone is keen to help support us, please do get in touch. And thank you very much. Bye.
Thank you very much. So our next talk in the session is from Dr. Amy Small, talking about the long COVID clinical pathway in Scotland. And Amy is the Chest, Heart and Stroke Scotland clinical advisor and also a practicing GP. And she herself developed long COVID in 2020, and through her advocacy work for people living with the condition, she got involved in advising the Scottish Government on post-COVID sequelae. So can I hand over to Amy? Thanks a lot.
Hi, thank you for having me today. I'll just give you a bit of background of how I got involved and who I am. So currently I'm 3 days a week as clinical advisor to Chest, Heart and Stroke Scotland. I am living with long COVID since April 2020. I was rather vocal in 2020 about the fact that we didn't have any care for people living with long COVID. And I wrote to the then Health Minister, Jean Freeman, and said, what are you going to do about it? I came from two angles, one that of my patients and one from the aspect of doctors who got COVID at work and suffered the sequelae of that. Through that, I was invited to a meeting with Chest, Heart, Stroke, who were bidding for funding at the time for their advice line team, which I'll tell you about later. And it was through that I started my work with them. I sat on the task and finish group that initially was set up by Jean Freeman to look at long COVID pathways, but it ended up being a group that looked at an implementation note that Helen has already managed. I also gave evidence to the Scottish Long COVID inquiry that Helen's talked about. And I also sit on the clinical and subject matter expert group arm of that strategic network. And I agree with everything that Helen said, that there certainly is lack of communication and transparency between the various branches of that group. The group that I am on meet 4 times a year. I'm also a part-time locum GP now, having lost my partnership as a consequence of my illness, and I work 2 days a week in that role. So we think this the last data I have is from the ONS stats from March. These numbers will have gone up since then, but we have an estimated 172,000 people living with long COVID in Scotland. £3 million has been made available from the Long COVID Support Fund in 2023, and those monies have just recently been allocated across health boards in Scotland. 3 health boards have no dedicated long COVID pathways currently. The Western Isles have a multidisciplinary team, which includes general physicians, which I was really pleased to see. And Orkney have a 0.5 whole-time equivalent dedicated physio, also supported by a consultant physician. Lanarkshire, Highland, Ayrshire and Arran, Greater Glasgow, Clyde, Tayside and Lothians all have AHP-only led services, and there are no plans for physicians to be members of those teams. So what do we do, Chest, Heart, Stroke Scotland? Well, we have an advice line made up of nurses, paramedic, OT. We now recently had the addition of a clinical psychologist who have been taking calls from people living with long COVID since early 2021. And they've got a wealth of expertise amongst them. They have been amazing at attending lots of meetings like this, as much education as they can as possible. They have learned all about POTS, dysautonomia, MCAS, all the allied sequelae of long COVID, and have been supporting people living with long COVID for well over 2 years now. We have 2 routes in. One, patients all over Scotland can just phone the advice line, or they can email in what we call reactive calls, where they can have one-off encounters and be signposted to other services that we have within the organisation. And then through other health boards, they can actually be referred in for what we call case management, where they can get that one-to-one support, usually for up to about 12 weeks. What they can offer, which the NHS can't, is time. Their calls last, on average, I think, about 45 minutes at least, in terms of support. And the reports we have from patients who've been through that have found incredibly helpful. If you look under the discussion points, these are all the things that they may or may not cover. So you can see that it's a really holistic approach to the patient. Everything from sleep and diet through to symptom management, anxiety, stress, vocational issues, finances. They can both refer internally to our peer support service. We have a long COVID online peer support management group, community support services, to physical activity, and our physical activity team are well aware of post-exertional malaise. They know when to get involved, when not to get involved. They know how to do it for those that are interested. And kindness support service, which has been so important for people who have been so incredibly isolated as a consequence. I noted that Carolyn's slide showed how family support, but what we do know all too well is actually a lot of people are losing their family. And as Helen alluded to, her own partner left her, and many others are being abandoned in this by both friends and family. And that's where our kindness support service can be really helpful. And they can also signpost to chest, heart, stroke publications, which we have co-created with the peer support group, and written material for patients. When we met with Jean Freeman, we talked about how what we could offer with chest, heart, stroke was one piece of the puzzle. And she was very clear at the time that what we were offering, both in terms of our advice line and then further pilots that we've gone on to do with Lothian, was part of the bigger picture. It was never meant to be the answer for Scotland. And I'm afraid that I think Scotland have fallen behind, led very down AHP-led services, and we don't have many, as you can see, long COVID clinics with physician input. Back when we met with government, I had invited the Hertfordshire long COVID team, who have an amazing multidisciplinary team led by a GP with a special interest, who has good access to other services. And I got her and her team to present to the government to show how a good long COVID service could be led and run. But unfortunately, that is not the approach that has been taken in Scotland. But what we've done in Lothian is we've worked alongside NHS Lothian and Pogo Digital Healthcare to create a supported self-management tool, a digital one. So patients fill out a questionnaire, a bit like the COVID YRS-19 tool, but it is different because it's very tailored to that individual person. They're not having to fill out lots and lots of questionnaires that aren't relevant to their symptoms, because we recognise the fatigue that can come from that. And on the basis of the answers they get, they're invited to be sent some tailored talks, which are presentations essentially, on subjects like breathlessness, pacing, fatigue management, and patients can watch them in their own home at their own time. And after that, they're given the opportunity to be referred through to the advice line team, where they get that one-to-one support if they want it. So far, we've had 233 patients referred to our services through the pilot and Mid Lothian, and it will be rolled out to East and West Lothian in August and Edinburgh by September, covering the whole of the Lothians. So what are the main issues? I mean, it's being repeated all over, isn't it? But as Helen said, the implementation note that was created is very hard to find. It's not widely used. It's very lengthy. My GP colleagues don't have time to sift through a lot of that, and are not going to find it particularly relevant, I'm afraid, as they're going to find it challenging to use. Coding remains really difficult. It's really hard for GPs to find the code within the systems that we use in Scotland. We use Vision and EMIS, and it's been particularly challenging to find that coding. which means we don't know the real live numbers. They're not being recorded. And that's why we are relying on ONS stats to give us the data that we have so far. And as we know, not all people trust ONS stats, and that can be easy for other people to hide behind. There's a general lack of recognition that this is a medical illness that needs treatment by doctors as part of a wider multidisciplinary team. Yes, rehab is important, but we can't rehab whilst people are still actively sick. And what we have seen in other long COVID clinics, like in Hertfordshire, is people won't engage in rehab till they know that it's safe to, till they've had the investigations that they need. And as we've said, with Carolyn's mentioned, it is a diagnosis of exclusion. And I think, sadly, too many people are being led down the rehabilitation route before we've got clear confirmation of what their diagnosis is and what the other additional problems they might have, such as dysautonomia. Like everywhere, all the health boards are having recruitment issues. So even though now the funds have been given to the various health boards, they're struggling to find the physios, the OTs, the other people to fill those roles. And I think particularly some of it's challenging because the funding isn't necessarily recurrent. So who wants to go for a job, jump out of where they're at for a 1 year or 2 year only contract? And this is a problem that we're going to have unless we know that that funding is going to be recurrent and there in permanence. My big disappointment with the way that we've done things in Scotland, I think, is the fact that because it's so health board dependent, not only have you got a postcode lottery, but that also takes away the sort of lack of educational network and shared experience. You know, how can we learn about the people that, for example, Carolyn says, who've come from Germany with their plasmapheresis and their scripts for apixaban? How are we going to know what's going on? Because we don't have a platform to share amongst our different services, because they're also very different with different people working in them. And unless we have clinicians embedded as part of those teams, I don't know that we're going to get much further forward with research that comes out. And that's a big problem I have with the way things have been done. I say, and I've said this in every meeting I think I've been in, if we can get the pathway right for long COVID, I think we can get the pathway right for all chronic disease. And I think as a GP, I too all often have seen patients with chronic disease who bounce around systems. They go see their GP, they've got some neurological symptoms, they've got some respiratory symptoms, they've got cardiology ones, and they get referred and they wait months, now years, given that the post-COVID world that we live in, and they're not getting that holistic approach. And I keep saying, if we can really look at this on a level where we can get it right for long COVID, we can extrapolate that out to many other long chronic disease conditions. And I'd really like us to remain curious about how we can do that. Thank you. I'm happy to answer any questions.
I'm going to introduce Geraint Jones, who's an advanced pharmacist in HIV and home care, and he works in a health board in South Wales. He shared his experiences of long COVID since contracting COVID-19 at work in April 2020, and he's written numerous articles for the Royal Pharmaceutical Society and pharmaceutical journals nationally and internationally, spoke virtually in front of the House of Commons as part of the all-party parliamentary group on coronavirus. He's also been involved in research trials relating to long COVID as a study participant, a co-investigator, and speaking in a personal capacity as a public patient representative. He's part of COVID-19 Airborne Transmission Alliance, a group of leading healthcare professional bodies and experts representing 64,000 healthcare workers who've recently been granted core participant status in Module 3 of the UK COVID-19 inquiry. Geraint is keen to pursue research into the improvement and maintenance of ventilation in healthcare settings, recognising the airborne transmission of COVID-19, along with other illnesses and diseases. Thank you, Geraint. I'll hand over to you.
Morning, guys. Thanks for the invitation to speak about my personal experience with long COVID. So yeah, as Jane had mentioned, I contracted COVID at work in April 2020. Pre-COVID, I was fit, I was well, playing football twice a week, gym 5 times a week. Hence my kind of volunteering really to go and work on the COVID-19 positive wards. Unfortunately, this has now left me with a multitude of health conditions, which I will kind of cover in the next couple of minutes. But yeah, it's just highlighting how even healthcare professionals themselves are finding it really difficult to navigate the healthcare system, not knowing who to refer to, when to refer. And it's only through probably perseverance and a really supportive GP who also was experiencing long COVID herself. And so we were able to share experiences to basically help each other. So these are photos taken by Gareth Phillips. He's a photographer, and he documented my journey throughout, I think it's just 2021 and 2022. And these images were taken as part of the cover scan study, which was one of the very, very early stage studies with Dr. Banerjee and at the team at Oxford. They've found a few different things which were quite concerned at the time. So pre these studies, I had been involved with the Nuffield exercise therapy. I'd lasted probably about 30 seconds doing a 6-minute walk test, and I just had to sit down. I felt really dizzy, really disorientated. And it was only probably about 2 months later that I actually feel like I was probably having some kind of what felt like a heart attack. Referred myself to A&E, and basically got kicked out of A&E for quote wasting someone's time. And I then sought private cardiology appointments where I was had MRIs undertaken and found out I had myocarditis. So obviously really dangerous to exercise while you've got inflammation of the heart. This then led on to further investigations, which were confirmed by the cover scan study, which showed myocarditis and also inappropriate sense tachycardia, which thankfully I'm now on medication for, which is going to be probably a long chronic heart condition at 33 years of age. I've had numerous tests for gastro issues, respiratory, cardiology, neuro. Even up to last week, I was still undergoing tests for either pancreatic or gallbladder involvement as well. And it's really difficult because even as a healthcare professional, you can talk the talk, you can speak to colleagues, and even then there seems to be a real reluctance to acknowledge long COVID, which I found really difficult. As someone who is quite research focused and research driven, I just find it fascinating how people can be quite stubborn in their ways to think that teach an old dog new tricks type thing. We've got all these advances in digital technology in the world. We've got all these different tests, like they mentioned earlier, like apheresis and microclots. And even then, there just seems to be a real reluctance to venture into the unknown, which I really struggled with. So as I said, I'm still going through numerous tests now at the moment. Thankfully, I'm probably about 85% pre-COVID, but again, that's whilst I'm on medication for my heart, my stomach, my cardiology symptoms, as well as taking numerous different supplements, which I feel have been shown to be beneficial in helping recover post-COVID. So this kind of leads me on to the next, probably my last slide as well. So as I mentioned, I'm looking at healthcare settings and increased air ventilation in hospital settings. Just obviously raising awareness about the airborne transmission of COVID-19, but also the real importance of being involved with the research studies. As a patient, I found it really difficult when I had no energy, basically no energy at all, to be honest, to get myself to these studies, to get myself to these Nuffield graded therapies, to push myself a little bit. And I just found that everything seemed to make me worse. But the only thing that really kind of probably kept me going was, aside from my small dachshund, was peer support, but also kind of faith that other people were doing things to help others. And like I said, the cover scan study really helped me confirm what I was feeling, which was a great validator at the time. But we are probably 2 years on now from those studies, so hopefully there'll be more information shared on, like the image shows, microclots, post-exertion malaise, just long COVID in general, and there's different options available for participants to be involved, like the Stomach ICP study, the Listen study here in Wales, because again, like others have alluded to, there are no designated clinics in Wales. It's just basically down to the openness and probably the interest of your clinicians. But I just hope that everyone's able to have probably 1% of the experience I had, because my experience compared to others is being probably a blessing in some ways, because I know others have had a really, really tough time. But yeah, if everyone can, keep attending these events, keep pushing the research, keep pushing what your lived experiences are, because it is really, really important, and it will help drive to change something. And like the others have said, even not just long COVID, but other chronic disease states as well. So unfortunately, my experience hasn't been the horror show of others. It hasn't been nice or pleasant, but thankfully, we're all able to use our experiences to help others. So again, thank you for letting me share my experience.
The last presentation of this session is another recorded present. It's from Byrne, who's a 19-year-old from Northern Ireland who's lived with long COVID since March 22, and is hoping to start a social work degree in September, and enjoys volunteering, playing guitar, and reading.
Good morning, everybody. It's nice to see you all, and I hope you're all doing well. Just a little disclaimer before I start speaking. I might cough and I might lose focus and concentration. I'm sure those of you who have long COVID can understand. I have a little sheet of paper beside me just to keep me on track. So thank you for your understanding. As introduced earlier, my name's Eden. I'm 19 years old and I'm from Northern Ireland, from Belfast. I was diagnosed with long COVID in February 2022, and I've had the whole range of symptoms, but after 17 months I've been able to get some form of treatment just in the last sort of 2 to 3 months. But there's definitely still a lot of work to be done. One of the main things I'd like to discuss today would be the lack of support available, in particular to those in the 18 to 25 age group. There's different services and support available for adults, and there's the Long COVID Kids charity for the younger age group. And although my age group does fit into the adult category, it feels like I'm the only one sometimes in Northern Ireland who's my age facing this health condition. And although I know that I'm not, sometimes it's hard to see that, especially when you don't even know where to reach out to or who to ask for support. I'm sure you're aware of how isolating the condition can be, and I think some sort of online group for young adults, or resources such as a blog or videos of those who have lived experience of long COVID could be really beneficial for people like me. It can be really hard to understand what someone's going through, and you can't fully understand it unless you're going through it or similar yourself. But the creation of resources to help peers or family members explain a bit more about what long COVID is and its impact would be beneficial, especially for those young adults, teen groups, as I believe they find it even harder to comprehend the daily struggles that we face. Sorry. In terms of provision and support available in Northern Ireland and the benefits and challenges of such support, the waiting list to be seen by any long COVID specific healthcare professional is approximately 1 year. But I am aware of those who have been on the list since the start of the pandemic and have just been experiencing the same symptoms since without any further support. Only 2 months ago, I was able to see a specialist, and my experience was pretty negative. I didn't feel like I was being taken seriously or being listened to by this specific health professional. They even referred me to a high-intensity exercise program, and here's me struggling to walk up the stairs. How on earth was I going to do that? They kept cancelling and rescheduling appointments, sometimes without me even knowing, and for someone who has chronic fatigue and brain fog, you can imagine how frustrating and challenging this was for me. A positive, however, was after my initial appointments, I started the post-COVID rehabilitation program at my local leisure centre. This provided chair-based exercises, relaxation techniques, a talk which provided helpful lifestyle tips, but most importantly, the opportunity to interact and have that peer support from others going through similar things and having similar experiences. After this programme, there was the opportunity to just further build up strength and resilience through a 12-week Pilates programme or circuit training, depending on your ability and what stage you are in recovery. I am starting this programme next week, and I'm looking forward to seeing how it is run. It's great to have this support in place, but what happens next? Some of these people attending have been waiting for 3 years. The waiting lists are far too long. Here in Belfast, the long COVID team allow you to avail of their support for a 6-month period after you've used their service, which doesn't seem like an awful lot of time, especially if you've been waiting 3 years for the initial rehab referral. When you get discharged, there is a worry that there's not the support available, and there's not that other ear at the end of the phone who has some sort of understanding. You might still experience these symptoms and be struggling every day, and we all know how long it takes to get through to a GP, even just to get blood results. And you might have to go through this whole process again once you've been discharged. I think as everybody's learning, and this is such a new illness, there's only so much the healthcare professionals and other people can do to support those with long COVID, but the main takeaways would be to listen, provide that support in a non-judgmental way, and make sure you don't overcomplicate things. It would also be really helpful if you could check medical records before they come into the appointment. It can be really overwhelming and exhausting having to repeat things over and over again, and it can really impact a person's mood and anxieties around even attending the appointment. The emotional impact of having long COVID is definitely a big thing. The stress of appointments and management of symptoms and the impact this has on mental health and well-being isn't always taken into consideration or talked about. And I think there isn't enough emotional support available, especially for those who have long COVID. I definitely say more awareness and understanding are vital amongst all the different services and different organisations, even in universities, schools and workplaces, as they might not be able to understand or have even heard of long COVID, so it would definitely be worth educating them further. Thank you very much for listening to my experiences. I hope you enjoy the rest of the webinar, and if you have any questions, feel free to ask. Thank you.
Thank you very much, Eden. I realise the amount of effort that must have taken. I wonder, there are a couple of questions that have been raised. There are quite a lot of questions, but just looking at the top of the list in terms of what has been spoken about today, the things that come out to the top of the list, it's quite a long question actually, and probably directed at Amy, Dr. Amy, and it's asking, to what extent will the developments aimed at creating ME CFS specialist services affect the creation of long COVID clinics in Scotland? And since the NICE guidelines on ME CFS recommendations, I wonder if you've got a comment about that. And I can't see, it's quite a long question, but it's about the interaction between ME CFS and long COVID services. Don't know if you have a comment on that, Dr. Amy.
Yeah, thanks. I'm not allowed to unmute my video. If the host could do that, please. Undo my video. I thank you. I can just do that now. So sorry, I wasn't quite clear on the question. It's whether ME CFS services are affecting long COVID services.
Well, will they affect the development of long COVID services?
I think the services for ME CFS are very patchy across the whole country. So for in Lothian, for example, we have an AHP led service. There was a physician that was involved in it years ago, but when they retired, they didn't make any provision to replace that doctor. There are very long waiting lists to get onto that service. I'm keen that whatever pathways we create for long COVID, like I said, for all chronic disease, that would include ME CFS, because I think that a lot of what we're going to discover through long COVID is going to unlock the key for so many people that have been forgotten for decades. The missing millions, they call themselves for a reason. One of the reasons I have been reluctant to date to lump the two diagnoses together is that I'm worried that if we do that, long COVID will be forgotten straight away. We're gonna leap to that next bit where we get put in a box. And I'm keen that whilst we've got I say government interest, I'm not convinced that we do, but whilst at least we've got some funding and research and other bits going on, that if we do try and keep them separate for now, we can get the data, we can get the research, we can get those pathways set up. And then I hope once those are well established and we can show how good services can really make a difference for these people, that we can then go, well, actually, can't we do this now for these other conditions? So I'm hoping that good will come from this. I remain an eternal optimist, but I think some people might think I'm too optimistic on that front.
Thank you so much for that. Thank you. I admire your optimism. There was a really interesting question actually came straight after Helen Goss's presentation, and it was asking about the involvement of lived experience across the UK in the other nations other than Scotland in strategic boards and oversight of development of services. So I don't know the answer to that, but Danny, you might have an idea, and I'm sure there may be other people, but I wondered if that's certainly something around learning lessons from each other. I guess, and in Scotland, we've certainly always been very keen to try. We with lived experience and have been very keen to look what goes on in the other nations. I think the setup is so different in each of the four nations in terms of how services have evolved. It's sometimes very difficult to compare. And I think that does make it very challenging. There was a question about a transition pathway when long COVID children progress to become young adults. I certainly, Amy, that doesn't apply in Scotland since there isn't a particularly obvious children's pathway, but I don't know if you have a comment on that. And Danny, you might as well have a comment on that. Transition pathway.
If it's anything like the rest of the NHS, it's not going to be smooth. When there's a patient with mental health needs, for example, kids with ADHD who then transfer to adult services, that is never smooth. It is always messy, and long COVID is going to be no different. There will be, I think, obviously provisions need to be made, but we still haven't even established proper services for paediatrics or adults, I would say, across the board. So unfortunately, I think, as usual, that group of people are going to be really struggling, sadly.